Today we will talk about renal and ureteric stones in the view of NICE guidelines. It's a very complex problem in primary care and we will try and tackle out in the next few minutes. I am Professor Fahad Rizvi. I am a GP in Leicester. My background was urology training all over the country, and currently I'm involved in teaching in a couple of universities, and also I do a lot of urological procedures in primary care. This short film will aim to provide the latest NICE guidelines for the management of renal and ureteric stones. It will be useful for the GPs and trainees to understand these new guidelines. Renal stones are formed in the kidneys and they travel down this thin tube, the ureter, coming down into the bladder from where they are expelled out from the urethra. They are mainly formed of calcium oxalate and phosphate, which accounts to 80% of them. The rest 20% are mainly uric acid, struvite and cysteine. The most painful part of the stones are as they are traversing through the ureter. This causes intense pain and bleeding caused by the injury to the ureters. So NICE has provided guidelines to standardize care and quality across the country. Renal and ureteric stones are quite common with a prevalence of around 10%. Males are affected more common than females, and the age group is between 30 and 50 during the first presentation. The cause for renal stones is often unknown, but they are quite common in people who have high calcium levels in their blood, which can be because of hyperparathyroidism, or people who have recurrent infections. They may get struvite stones. It is also linked with family history and people who are housebound or bedbound, people who don't drink enough liquids. They may cause stagnation of urine and may lead to kidney stones. Stones are important because they are very, very painful. Some people mention that they are worse than childbirth. Now, we also have complications linked with kidney stones, and they could be things like sepsis, which may be life-threatening, or you may get a ureteric stricture or irreversible kidney damage. As a clinician, we see loads of patients with abdominal pain, and one of the reasons may be a renal or ureteric stone. These patients present with a loin to groin pain, which may radiate to their perineum. The pain is often sudden in onset and may last for minutes to hours. It can come into spasms, or maybe they are constant. Patients will often have nausea and vomiting along with this pain, which is caused by the pain itself. The diagnosis of renal and ureteric stones is mainly done on a basis of a good history, examination, for example, dipstick urine for hematuria, and the use of imaging, for example, CT scans and ultrasound scan in pregnant women. There are lots of differential diagnoses of people coming with loin to groin pain, and there could be a problem in the kidney itself, which could be like pyelonephritis or a blocked kidney with some other reason. It could be because of a gynecological cause like a ruptured ovarian cyst. It could also be things like diverticulitis or appendicitis or ruptured aneurysms. It is quite distressing to see patients with renal and ureteric colic in primary care. The initial management is to provide them with NSAIDs, which will be like intramuscular diclofenac or parectal diclofenac. They may also need intramuscular antiemetic like metoclopramide. If the pain is controlled, then I would send them home with some baseline investigations, which includes their kidney function test, their serum calcium, and organize some urgent CT scan. If the patients are not stable and they are still in pain, they may need more analgesics like morphine or intravenous paracetamol as per the NICE guidelines, so they would require hospital admission. I would organize urgent hospital admission if the patient is at risk or the kidney is at risk. So it could be like, an example, someone is pregnant and has a renal stone, they should be offered admission to hospital. Patients who are in septic shock or with a high fever and tachycardia and high respiratory rate should be offered admissions. And similarly, people with transplanted kidneys or having a single kidney are high risk. The recommended imaging for kidney and ureteric stones is CT KUB. This CT scan is a low-dose, non-contrast CT scan which can be done in minutes and can provide good quality images and locate the size and shape of the kidney stone. In patients who can't have a CT KUB, can have an ultrasound scan, and this is for patients like pregnant females. We can look further into NICE guidelines, which provide a detailed chart of management and prevention of stones, and it's a very useful tool to look at, and I'm sure the clinicians and patients will find it useful. So my advice to my colleagues and patients is to drink plenty of water, which is 8 glasses every day, which equates to 2 liters. They may wish to add some lemon for taste and also to decrease the formation of stones. NICE guidelines also advises to consider adding potassium citrate for patients with recurrent stone formers, and also may consider adding a thiazide diuretic to their medications. NICE provides very clear and easy guidance for management and prevention of kidney stones. I hope you found this video useful. Thank you for watching.